need to add more knowledge, like add recent knowledge to this model so that it can be able to generate information that is relevant and that is accurate. We need to supplement its knowledge base. So that looks like this in like simple image form. So a user asks a question through an interface. The interface could be a mobile application, could be a web, could be voice, could be anything. And this question is sent through a large language model that interprets the user intent. What is this user trying to get out of me, right? And then we have a retrieval augmented generation pipeline, which is the arrow that you see pointing towards the big box written vector database. So what that does is, from the question the user has asked, can we find relevant existing documentation within our data source that we have, so that whatever the model generates as an answer, we can point back to a context that exists within our database. So this pipeline, or this approach towards large language models, ensures that every answer that is generated by large language models is accurate, is fact-checked, because we have control over what goes in the vector database. It also ensures that we can have the model as up-to-date as we can, run the pipeline. So I think in media, what that would mean is, if you, in the previous speakers' talk, we've seen a lot of talk about hallucination. We've seen a lot of talk about the model does not generate answers that is in our context. We can't fact check what the model has said. So this is a technique or an approach that ensures that everything that the large language model generates as an output to the user comes from a data source that you can control. So the things that build our database in this context is the registry data and also scientific research journals, to be able to help clinicians, for example, make decisions for their patients. So what value does this system have? We have enhanced cancer surveillance, because, as I said, if we can answer questions around distribution and incidence of cancer in the country, then we have a way to get real-time analysis and reporting of cervical cancer in the country. We also have improved resource allocation, where insights to guide evidence-based policy, then direct funding decisions. So there's no reason for the government of Kenya to keep emphasizing on users to do pap smears if there's no documented evidence that by the time you're doing a pap smear, the patient already has cancer. So maybe it would be better if we put these resources that we're doing, these resources that we're using to market screening, maybe we should use them to market vaccination. So, and you can make that decision based on evidence. We also have improved clinical outcomes to reduce burden of disease. So this is value to the clinician who's seeing the patient, where as I'm making a decision on what is the next step or the treatment plan for this patient, I can say that I'm generally doing this because I have evidence that this is going to make the journey of this cancer patient easier. Also global recognition, where we aim to position the National Cancer Institute of Kenya as a leader in leveraging artificial intelligence for cancer care, which is not something we have seen so far. So that brings me to the end of case scenario 2, and this is maybe my second last slide, where I talk about case scenario 3, where we're using AI to personalize patient education after a clinical visit. So this is, I think, one of the simplest use cases that we have, where I think most of you will resonate with this. Sometimes at the end of a clinical visit, like you've gone to a doctor, you are not feeling well, you leave the patient, you leave the hospital, and you cannot explain what has happened in that room. You just know you are told, go do this test, come back, okay, you have this. Probably one of my worst words, because there's nothing like that, is blood infection. please don't use that word. There's nothing like, I have a blood infection. I think that's a very common word people say after coming from the hospital. I was told I have a blood infection, like infection kwa damu. That's not accurate at all. So essentially, this is the problem we are aiming to solve with this use case, where patients struggle to understand the diagnosis, the tests that were done, treatment plans that they were given, then leading one to poor adherence, because if you're told to come back after 5 days and on the 3rd day you feel well and you don't know why you are being told to come back on the 5th day, then you don't come back on the 5th day. It also improves health outcomes, because if you adhere to the treatment plan that you're given by your clinician, then you have better health outcomes. So our solution is to use large language models. Our solution is to use large language models at the end of a clinical visit. So this is where you already have an electronic health record system. So the clinician was already keying in your details in some form of system or computer software. And then, so at the end, when they are trying to save the visit, they take consent from the user or the patient, where they tell you, are you okay with us running your summary through a large language model, so that we can be able to generate a message to you as the patient that makes it easier for you to understand what has just happened in this clinical setting. So that's kind of the workflow that we have, where clinician records encounter details in the electronic health record as normal, and then consent is taken to use large language models on their data. And then if consent is given, then information is sent to the large language model and instructed to generate an easy to understand summary. And then again, a human in the loop, the clinician has to review the generated message